rectified now. So yeah, this month we have Professor Guillaume Millet from the University of Jean Monnet in Saint-Etienne. He's going to be talking to us about measuring fatigability in clinical populations. Is it relevant? Hopefully this stimulates some good discussion afterwards, and I'm really looking forward to hearing Guy talk. So without further ado, I'll hand over to you, Guy.
All right. Good morning, everyone. First, I'd like to thank me for inviting myself to this webinar. Okay, seriously speaking, thank you, Paul, and the other organizers. I'm not even sure who are actually the organizers of this seminar series, but it's a very smart idea. So thank you guys for launching this. This is great. My understanding is that it started from both Northumbria and ECU in Perth, and this is if this is true, this is funny because I actually have a special connection with both universities. For Northumbria, I know Paul and Stuart quite well because I was actually the external for their Viva. And of course, John Temesi is also there, so special connection with Northumbria. And I actually did my sabbatical at ECU in 2008 with Ken, Tony, and another Paul Lawson. So yeah, it was funny when I saw that. I was like, okay, so I have to take part of this. Okay, so before I start talking about science, I would like to introduce my lab, which is the Inter-University Laboratory of Human Movement Biology. I am actually, since September, the lab director, and with 3 deputy directors in Lyon, Saint-Etienne, and Chambéry, University Savoie-Mont-Blanc. So this is a lab on 3 universities, and so we are all of us are located in the southeast quarter of France, as you can see here. And so overall, this is 110 researchers, medical doctors, postdoctoral fellows, PhD students, engineers, etc. So 110 people working in the fields of muscle biology, exercise physiology, biomechanics, and neurosciences. And you have the 6 teams that are in the lab. So one about vascular biology and red blood cells. The second one is about muscle biology. The third one is working on atherosclerosis. We have one team working more specifically on fatigue, and I am obviously in that team. We have a sports performance and injury prevention team, and the last one is more about mental processes, cerebral plasticity, and motor performance. Yeah, I am physically located in Saint-Etienne, and we are very fortunate to have very nice facilities. So everyone is welcome to visit us anytime you come to France or to Europe. Please come to visit us. So in total, in this lab, it's actually a lab and the sports medicine. We have 2,000 square meters of facilities. So it's pretty, and it's actually a new building. So it's 5 years old. So it's a pretty cool area, pretty cool facilities. And I'm also very fortunate to work with many students since I was in Calgary, and I'm back in France for 2 years now, and I was very lucky to get good funding to supervise or co-supervise many students. So those are the people directly under my supervision or co-supervision. So I feel very fortunate to have all those good students and fellows working with me. So yeah, so it's obviously for those of you who know me, mainly or only about fatigue, both in the chronic, in the clinical side, so the chronic fatigue and health side, and also on the sports and performance side. And this is more about what we call acute fatigue. And this is the goal or the topic today will be to see if whether or not we can actually connect those 2 areas, which are actually quite different. So when we talk about fatigue, and this is the case for my 2 teams, I would say that I just presented. So we have chronic and acute. Chronic being defined as an unrelenting feeling of fatigue that is not improved by rest or sleep. So this is very important, and usually it interferes with daily functioning and socialization, that kind of thing, or return to work. Acute fatigue is completely different. So the usual definition that we give, we can probably discuss for 3 hours about just about the definition, but for today we'll use the simple definition, which is an exercise-related decrease in maximal isometric force and or power. And so you can call that chronic and acute fatigue, but more and more people are calling that respectively fatigue and fatigability. I guess it doesn't matter much as long as we know what we're talking about. Let's start about the chronic one, the fatigue aspect. So this is a feeling, and it's very prevalent in many chronic diseases. And in that talk, I will mainly focus on 2 diseases, which are cancer and multiple sclerosis. So in cancer, fatigue is experienced by almost everyone during treatment. 80 to 90% of people can experience fatigue. And even more problematic probably is that 1/3 of the cancer survivors after treatment still experience fatigue. In other types of some types of cancer, such as myelodysplastic syndromes, we just published a review with Callum Bronstein showing that actually 90% of people are still fatigued, are chronically fatigued. In multiple sclerosis, this is the same thing. As you can see here, physical fatigue as well as mental fatigue are also very prevalent in this disease. And again, this is only 2 examples. I could cite almost all the chronic diseases, and usually fatigue is really, if not the first complaint from the patients, it's really among the highly cited symptoms. So since this is a feeling, the way to assess fatigue is questionnaires. So here you have 2 examples. So the functional assessments of chronic illness therapy fatigue, the FACIT-F, and the European version of this, which is the ERSCT or TC, Fatigue 12 questionnaires. This is both mainly used in cancer, but you have many other questionnaires such as the FSS or MFIS questionnaires. So yeah, this is usually the way we assess fatigue using questionnaires. To assess fatigability or acute fatigue, and I'm sure that most, if not all of you attending to this webinar are very familiar with those techniques. So I'm not going to spend too long on that. I'm sure you know that the way we assess neuromuscular fatigue or even neuromuscular function in general is to measure force or EMG during voluntary contractions or when the muscles are at rest. So we either superimpose a stimulation, so it could be electrical or magnetic stimulation at different levels, could be muscle, nerve, cervical medullary, or transcranial stimulation. And we do that again during contraction or when the muscles are at rest. And the very basic measurements that everyone knows is, for instance, voluntary contraction, when we superimpose here. So this is a typical curve, typical trace before and after one of the ultramarathon that we have studied. So obviously a completely different topic compared to what we are going to discuss today, but just to illustrate the method. So here you can see after the race, when you superimpose to an MVC a doublet, here you have a huge superimposed twitch or superimposed doublets, and you can calculate voluntary activation. And we have consistently shown that after ultramarathon, voluntary activation decreased by 20 to 30% in the quadriceps. And this is actually the same, and this is funny to show or to say that this is actually the same, if not more, during a 2-minute MVC. So for 2 completely different type of exercise, you can have a huge central fatigue. Obviously, the causes of this central fatigue are different, but still the same reduction in voluntary drive. Okay, so if we try to look at the studies that have investigated fatigability in chronic diseases and in particular cancer, there are not that many in cancer actually. I haven't counted recently, but I would say 5, 6, less than 10 for sure. This is one example. So here they measure. I can't even remember exactly which muscles which muscle was assessed here, but it's the upper limb for sure. So what they showed here is the normalized twitch force was reduced in both the cancer patients in black and the control groups in white. And at exhaustion, actually, the peripheral fatigue was less in the cancer group. And so the conclusion of the authors was that the central command was actually attenuated in the cancer patients compared to the control group. So that type of setup is usually the kind of setup you will see in cancer field, and I would say in chronic disease in general. Here is another example. So this is a fatigue induced by 45-second sustained MVC of adductor pollicis in multiple sclerosis patients. And as you can see here, there is a reduction in voluntary activation in patients and not in control. So in control, this is what you have. So I don't know if you see my mouse here, but the superimposed twitch in control patient was not much different between pre and post 45 seconds sustained MVC, but the peripheral fatigue, so the electrical twitch here, was significantly reduced in the control group. And for the patients, it was actually the opposite. You have a huge increase in the superimposed twitch and not much difference between pre and post for the twitch evoked at rest. So this is definitely interesting. And an interesting observation from a very recent paper that we discussed last week in a journal club was that most studies investigating the underlying physiological mechanisms of fatigability in multiple sclerosis field are performed in isolated hand models. So as you can see here, this is the majority, 17 out of 23. And actually the most frequently used protocols use the isometric contractions and actually sustained contractions. And this is fine. I mean, this is definitively useful. We need that kind of study, that kind of fundamental studies. They are needed, and I'm not saying that we should not do that anymore. But I'm just wondering if this is appropriate to examine the link between fatigability and fatigue in patients. So yeah, if you do that kind of test or fatigability measurements, so it's usually single joint isometric contraction, most of the time upper limbs. Yeah, the good thing is that you can measure during exercise, but as I said, this is mostly upper body isometric, and it doesn't really represent exercise performed in sport and rehabilitation. And as Duchateau and Enoka mentioned, yeah, again, this is mainly in hand muscles, and future studies need to examine limb muscles. So the other option, if you want to assess fatigability, and this is, for instance, what we and other people here listening are doing, we study fatigue or fatigue and neuromuscular fatigue. We are measuring force and evoked twitch, etc., before and after human locomotion, for instance, walking, cycling, running. So this is good because this is ecological. And it represents the reality of daily life in either athletes or patients or rehabilitations in patients. The problem is that there is a need for time to test the subject. So depending on the type of exercise, sometimes this is not really an issue, but sometimes it can be an issue. So there is this problem of recovery when you go from the bike, for instance, to the chair to be tested if you're interested in the quadriceps. And we have shown with Christian Freud in 2013 that that was an intense exercise, but still, in 2 minutes, you have a huge recovery. So here, this is single twitch recovery after intense fatigue exercise. But as you can see here, in 2 minutes, you can recover 20% of the twitch. So the conclusion here, if you were taking 2 minutes to bring the person from the fatiguing task to the chair to measure fatigue, will be okay. So the twitch is reduced by 40%, and the rate is that it was reduced by 65%. So obviously a huge difference. And probably even more problematic is that because you also have a recovery of the central nervous system. So here this is only muscle twitch, so muscle fatigue measured by the twitch. But the central nervous system probably recovers faster. So not only you underestimate fatigue, but you can also misinterpret fatigue if you take 2 or 3 or 4 minutes to measure neuromuscular fatigue. So what we try to do, we try to use the best of the two methods and to propose this innovative bike. So that was published in 2017. So the idea was very basic. It was to do a whole body dynamic exercise, so cycling. It was recumbent cycling, and to measure directly force on the pedals, and to have a system to lock the pedals so that you can be, as you can see here, you can be, when you test the subject, you can be in a position that is similar to what you will get in a chair, as you can see here. So, and then we can do stimulation, TMS, etc., etc. So, and then you can use the bike to do different types of tests, but we have mostly used it using what we call the KIF test. So this is something that we published 7 years ago. It was an isometric incremental test when we measure MVC plus stimulation, etc. after each set of 10 submaximal contractions. So it was initially 10% MVC, 20% MVC, 30% MVC, etc. So here we use the same idea, so semi-incremental exercise, but on the bike. So that's what we use for most of the studies that I will show you. I will show the results in a couple of seconds. Another option is to measure fatigue during dynamic exercise, and more specifically during a sprint. So if you do that, so each point here is, so because we are also measuring force on the bike, of course, during the sprints, and we can measure angular velocity, you can have this force, this nice force-velocity relationship. So each point is a pedal downstroke, and on the right, you have the power output angular velocity relationship. So you can determine the maximal power here, and so assess maximal power pre and post fatigue exercise. And this is what we did with one of my PhD students when I was in Calgary, Renata Kruger. What we did, we compared the fatigue measured by isometric contraction versus maximal power. And we did that for 3 different types of exercise, namely the Wingates, 10 minutes, and the intensity was 5% above the second ventilatory threshold, and the prolonged exercise, which was 20% below the first ventilatory threshold. So obviously the subject came 6 times in the lab. So they did either, for instance, the sprint with the Wingate and the sprint again, or then the second session was the AMVC, Wingate, AMVC again, etc., etc. So 6 times. And again, if we consider that fatigability is defined as an increase rated decrease in maximal isometric force and or power, are we really talking about the same thing? And the answer is no. If you look at the fatigue index, if we consider that the fatigue index is the decrease in IMVC, isometric maximal volunteer contraction, then you would say, okay, so the most fatiguing exercise here among the 3 was the 10 minutes. Okay. Now, if you consider the reduction in power as the fatigue index, then it's a different story. Then you will say, okay, so what is the most fatiguing exercise? And now this is the Wingate. So this is, I think, important to keep that in mind when we assess fatigue, as most people do using isometric contraction, including us, obviously. We are only describing part of the fatigue response. And this is, I would say, particularly important when you consider fatigue in aging population. So we published, still with Renata, a paper in MSSC in 2018. So it was a meta-analysis. And what we found is that depending on how you induce fatigue and how you measure fatigue, the final outcome could be completely different. So for instance, here, if you consider fatiguing exercise as all the isometric tasks that have been published and the measurements as isometric contraction, you would say, okay, so the young are more fatigable. Now, if you consider as a fatiguing exercise the dynamic task only and still measuring fatigue using IMVC, then there is no difference between the old and the young. And now if you consider fatigue exercise, so both isometric and dynamic, but then the measurements is not isometric contraction anymore, but it's maximal power, then the conclusion is the opposite. You would say, okay, now the aging, the elderly people are more fatigable. So this is, I think, relevant to at least keep that in mind when you assess fatigue. Okay, so the title of this presentation was to basically try to make a link between the two, if possible. So does it work? Is it relevant? So, for instance, if you continue going back to cancer, we know that cancer and cancer treatment can induce cachexia or a reduction in specific force, which is the force production divided by the cross-sectional area, and also a change or an altered muscle metabolism. So this together will induce a reduction in peripheral function, in muscle function. And because we know that we have feedback, I didn't detail that, but I know that most of you are familiar with that. We have also an influence, a direct influence on the central nervous system mechanisms. And so both will lead to a reduction in physical performance and fatigue. So in that study where they compare, for instance, Hodgkin lymphoma survivors with control, there was definitively a difference in terms of perceived fatigue, in terms of general fatigue. And here they didn't show any difference in terms of MVC, cross-sectional area, as well as intrinsic force, or muscle, what they call muscle quality. Here they didn't measure fatigability. So the question was not, okay, so is there a reduction between cachexia or specific force reduction and general fatigue or chronic fatigue, but well, we can still study that, but it's more about fatigability. So in that paper that I already presented, they tried to directly address that. So measuring fatigue using it's in MS, multiple sclerosis. So they measure fatigue using the MFIS questionnaire, and fatigability, they measured it using two different tests. So the first one was a sustained isometric fatigability test, 2-minute MVC. And as you can see here, there was no relationship between fatigue and fatigability. And the second test was a bit better. I'm not sure if I should use that term, but a bit more ecological, I would say, because it was at least dynamic. So it was an intermittent concentric fatigability test, still 2 minutes. And now they found a significant, relatively weak, but still significant relationship between fatigue and fatigability. Still here, it was maximal concentric contractions, and it was still single joint. So how about our innovative bike, which is supposed to be more representative of daily life and rehabilitation? For instance, in this paper that is going to be submitted soon, and that's a paper, a study that we conducted in Calgary with a couple of people that are probably listening today, including John, etc. We found that, so here we have the reduction in MVC, so what we call fatigability, at different stage, the stage that you can see here, and the stage were actually a scale based on body weight. So the first stage was 0.3 watt per kilogram, and then 0.6, 0.9, etc. And what we found is a difference between non-fatigue and fatigue people. Non-fatigue and fatigue being obviously the fatigue assessed using questionnaire. So here the FACIT-F test. And we found that the non-fatigue people, they tended to be, as you can see here, it's not a tendency, it's a significant, to be less fatigued for a given task. So fatigability was better in the non-fatigue cancer patients compared to the subjectively fatigued group. This was unfortunately not explained by peripheral or central fatigue, so we are not able to determine if it was more peripheral or central. However, the non-fatigue group, and this is, I guess, relatively expected when you see that, is that they were able to go further, so they have a better performance overall. So non-fatigue group had a better time to task failure compared to the fatigue group. So this study was much more comprehensive than just doing the test on the bike. As you can see here, there were blood sampling, demographic body composition, maximal exercise tests, so cardiorespiratory measurements, obviously patient-reported outcomes, disease-related factors, and the test that I just presented. So there was a TMS, electrical stimulation of the femoral nerve, etc., on the bike. And so the idea was to try to explain the subjective fatigue, and I'm sure you now understood that. So the subject, so we tested almost 100 patients, so half of them, or a bit more than half, were fatigued and 42 were non-fatigued. So it was a cancer survivor, so not during treatment, it was off treatment. And so they had to come twice in the lab. So the first visit was to do the maximal test, the body composition, etc. And during the second one, they did blood sampling and the fatigue test on the bike. So here you can see the group comparison between the fatigue and non-fatigue. So I already presented the change in MVC here. That was less for the non-fatigue group, so less fatigability. It was associated with a better VO2 peak in the non-fatigue group, a better time to task failure, as I also presented in the previous slide, and also a low inflammation here in the non-fatigue group, as shown by the TNF-alpha parameter. And now if we do a regression analysis, so a multivariate model, the factors, the variables that were significantly associated with the chronic fatigue, with the fatigue F, were the reduction in MVC at the last common stage, which was the third stage, as I showed you, VO2 peak, TNF-alpha, and age. In another study, still in cancer, but this time, so the one I just talked about was cancer, different types of cancer. So this study published this year in European Journal of Applied Physiology with Colleen Lavigne and Rosie Tuome. We assessed the effect of treatment. So it was radiation therapy, and chemotherapy. And so this is the duration of the treatment, and we assessed. So we compare we assess the change in chronic fatigue, subjective fatigue, with still with the facet F, with different parameters such as the MVC, potentiated twitch, as well as exercise time. And as you can see on the right, there was a significant relationship between the change in the facet F and between pre and post treatment, and the change in exercise time, leading us to suggest that this is definitively a factor that can contribute to the feeling of fatigue. I mean the fatigability or the performance. Here is the change in MVC and potentiated twitch force between pre-treatment and post-treatment, and as you can see, there is a reduction, and also during the last common stage, there is also a difference between the two times, pre and post treatment. So again, there is definitely something here that tells us that the fatigability may play a role in the chronic fatigue that people are experiencing. And the last study on that topic that we recently conducted, and again, this has been published this year in G Neurophysio, was a similar design as the cancer one, except that it was in multiple sclerosis. So again, 2 visits where we measure, again, blood sample, the same test, cardiorespiratory parameters, etc. Plus, we have some specific measurements due to the population, multiple sclerosis, in particular core temperature, because we know that multiple sclerosis patients have troubles to regulate core temperature. So we wanted to assess whether or not that could be a factor explaining the difference between low and highly fatigued patients. Of course, we did questionnaires, and we also did a sleep evaluation using actigraphy, so 2 weeks actigraphy. So here we compare 3 groups. We compare the people with control with 2 groups of multiple sclerosis patients, one being what we call the high fatigue, so they were above a certain threshold for the questionnaires, and the low fatigue, which were below the threshold. And what we found is that, so we did TMS as well as electrical stimulation on the bike, and we found that the corticospinal excitability was actually different between the 2 groups. So there was no effect on the exercise itself. So you have the same design here. You have baseline, and then you have the first, second, third stage on the bike. And we stopped after the 3rd stage because, again, as in the cancer study, the 3rd stage was the last common stage. So the last stage that everyone was able to achieve. And then we have post, which is exhaustion for everyone. So here there was no effect of the fatiguing exercise itself on corticospinal excitability. It stayed pretty constant, but there was a difference between the 3 groups, with the control subject being higher than the low fatigue group, and that is also higher than the highly fatigued group. And that was true for both the vastus lateralis and rectus femoris. The silent period was slightly different. So again, the difference between the group, but here that's the difference appeared during the fatiguing exercise. So the low fatigue group tended to increase. The control group was pretty constant, and the highly fatigued group, there was actually a reduction or a tendency at least toward a reduction in corticospinal excitability, and that was only true for the vastus lateralis. And in terms of fatigability, so the first measurements, the stats are not super clear, but globally, I would say that it goes in the direction that we expected, and it was significant only at exhaustion. But as you can see here, there is something, meaning that, again, for the reduction in maximal isometric force on the bike at each stage, the highly fatigued, subjectively fatigued patient seems to experience more reduction in force for a given task. And this is less clear for the peripheral twitch. It seems more that the true multiple sclerosis patients groups were lower, but that was not significant. So there are, I mean, I don't know if I convince you that there is something, there is a relationship between fatigability and fatigue, but at least, and I'm not saying that this is enough. And okay, so I demonstrated that there is a relationship, but at least it's worth trying to investigate that more, I believe. I hope I at least convince you to do that, or to that this is a good idea. So if this is true, what could be the reason? So if we consider that fatigue is a reduction of maximal force or power, so a reduction of functional state. So now if you have the same workload, if you have a given workload and you have a higher workload, obviously you would expect a higher reduction in force, for instance, and so that the person will take longer to recover, right? So now if you replace low and high workload with someone having a normal fatigue resistance and a deteriorated fatigue resistance for the same workload, you will still get the same thing. So in green, you have the person with the normal fatigue resistance, and in yellow, the person with the deteriorated fatigue resistance. And if this is true, then you may expect that there is accumulation of fatigue or of fatigability during the day, and day after day, maybe that can partly explain their experience fatigue they are feeling chronically. And this could be related to both feedback mechanism course, we know that that can play a role. If you climb the stairs and you're above your lactate threshold, you will feel it more difficult. So the sensory pathway from the periphery, and we know that this is also, if you are more fatigable, if your muscle fibers are more fatigable, then you will need to increase the central command. And there is this theory that, yeah, you have a copy of your central command of your efferent signal to the sensory cortex, and that could also participate to the higher feeling of fatigue. But in reality, it's probably not like that. I mean, people will not accept to get a higher level of fatigue. So if they are more fatigable, so this is the people on the left here. If the people with the highest fatigability, they will probably increase their fatigue level during the day, and at some point they will reach what we call a tolerable fatigue, so a ceiling. And if you have on the right the much lower fatigability, then of course the work that you can do during the day is much higher. And so if you are not able to do as much work because you have this high fatigability, what you will get is that, yeah, you get fatigue. So because you cannot reach this level of activity, you tend to adopt sedentary behaviors like that. And if you do that, obviously you get more decondition. For instance, you get more muscle atrophy, and this will probably reinforce the level of fatigue that you will experience. So this is what we call the vicious cycle of fatigue. And I don't know if I have time, but I published almost 10 years ago, meaning that I'm old, but that's a different story, a paper on a completely different topic. So that was about fatigue in ultramarathon, that this model called the flush model, when I assimilated fatigue or perceived fatigue, RPE in that case, to the level of water that we have in a tank of a flush toilet, and that was dedicated to ultramarathon or endurance sports. But in a way, this could almost be applied to what people are experiencing during the day. So when the tank is full, and you have to stop. So I believe that low acute fatigue resistance cannot fully explain, at least not directly, chronic fatigue, but it may contribute to chronic fatigue. And again, this is provided we measure it appropriately. If we do a 2-minute MVC, I'm not convinced that we can evidence such a relationship. So it makes no sense if we are not considering the big picture. So what are the different causes of chronic fatigue? And I didn't have time to go into details. I wanted to focus on the relationship between fatigability and fatigue, but obviously this is not the only parameter, the only variable that can explain chronic fatigue. And so why is it important to assess, in addition of trying to understand chronic fatigue better? I think another reason why we may want to assess fatigability is, and other factors, but particularly fatigability, is that it may help us to tailor training interventions. So for instance, if you see that you have a reduction in force and a reduction in muscle mass, then you may want to do strength training dedicated to increase muscle mass. You may want to add electrostimulation, and we also published a paper about that recently. If you feel like okay, so the voluntary activation is an issue, there's a reduction in central drive at rest, then you may want to do also strength training, but a different type of strength training. If you see that the fatigue resistance during the test is low, and it could be associated with a low cardiopulmonary fitness, then of course you are not going to focus on strength training, but you are going to do more endurance training and probably interval training, high intensity endurance training to improve your cardiopulmonary fitness, etc., etc. So if this is more an issue with inflammation, etc., you may want to do endurance training, but this time probably more low intensity endurance training. Same thing if you realize that the problem with the patient is actually more the sleep. If you have sleep disorders, then there is no real reason to do strength training in a room. You may want to ask them to do more outdoor endurance exercise late afternoon. So there are probably a way to tailor the training intervention so that people are doing the right thing at the right moment. I'm done. Thank you very much to you guys for listening, and obviously to all my colleagues and trainees. So yeah, it's very important to acknowledge the work done by these awesome people, and I thank you for your attention.
Thank you very much. That was really interesting. So if anybody has questions, feel free to either raise your hand using the hand raise tool or just type them in the chat. We have one from Ken Nosaka to kick off with.
I'm not answering any question before I have at least 50 more followers on Twitter. So ask your mom, ask your sister to follow me. Okay, Ken, yeah.
Okay, thank you very much for the nice presentation. Very nice. Okay, so what is the time frame for the acute and the chronic? So, for example, as you know, after eccentric exercise, strength loss sustained for a couple of days or sometimes a week. Is that considered to be acute or chronic?
Acute.
Acute, still acute.
Yeah, still acute, yes. So chronic is when we are talking about chronic, we are talking of people who are fatigued for weeks, months, and years, and they never recover. So it's a bit like in athletes, it will be like overtraining. So overtrained athletes, even if they rest for many weeks or months, they are still fatigued. They are still experiencing fatigue. So muscle damage is, well, I'm not going to explain to you what is muscle damage. You know that better than everyone else. But this is, I would say, something, of course, this is not acute fatigue, but this is more similar to acute fatigue, I would say.
Okay, thank you.
Okay, we have a question from Ricardo Mesquita. Ricardo, if you want to jump on the microphone.
Thanks, Paul. Thanks, Guillaume. Very nice presentation. I was just wondering about the comparison between the isometric indices of fatigue and the dynamic one. And I was wondering what was the type of population under study. And then it got me thinking whether these differences would be influenced by training status. For example, if we had a cyclist used to do cycling sprints versus someone who's not a cyclist, and would that modulate the differences?
Yeah. Okay. So, well, in the study that I showed, it was multiple sclerosis patients. So it was patients and fatigue patients, if I remember. Okay. So of course, if you are considering cyclists, this is probably a different story. But then I don't think the comparison is relevant anymore because they are not chronically fatigued. So you cannot look for a relationship between their fatigability resistance for different tasks and the chronic fatigue because they are not chronically fatigued.
Yeah, I was more asking about the sensitivity of assessing fatigability with the MVC versus a 7-second sprint, like you did with the Renata's study in 2018.
I think you are talking about the study comparing the two tasks and trying to relate that to fatigue. Okay, so yeah. My bad, sorry. So the question was if there are experience in repeated sprints, would that influence the final outcome, basically, right?
Yeah.
Yes. I don't know, probably. Yeah, probably. So this is another reason, I guess, or another factor that can explain the difference. In our study, the people were not trained in either they were not familiar with isometric resistance, I mean to sustain exercise, isometric sustained contractions or sprints. So they were just regular people in the lab.
Okay, thank you.
Ken Nosaka, is your hand up again, or is that your original hand up? I see you may have another question.
Yes. Okay, thank you very much. Sorry. Is the cause of fatigue different between fatigue assessed by IMVIC IMVC, and that by power during cycling. For example, did you see any correlation between the two parameters, such as the participant who showed large decrease in IMVC also showed large decrease in power? Time course was different, but actually in general they are correlated each other.
Yeah, it's a good question. So this is not the only time we did this comparison. So we did it in Renata's paper, and we also did it more recently during an ultra marathon study, actually trail running and ultra trail running. And so in the first study, there was no relationship whatsoever between the decrease in MVC and the decrease in maximal power. But in the other study, there was actually a good relationship. And the difference was the fatigue exercise were totally different. So I showed you the type of exercise we assessed, that it was still relatively intense. And here, there is no relationship. And we suspect that the reason is that the factors that affect maximum contraction velocity are different compared to what is affecting isometric strength. For instance, accumulation of ADP could be a deleterious factor for shortening velocity and maybe less for strength. Okay, but in the second study, because we have a huge central fatigue, and then the central fatigue probably explain why the relationship was actually quite high between the decrease in IMVC and the decrease in power, in maximal power.
Okay, right. Thank you.
Okay, I have a question, if you wouldn't mind. So, if those experiencing greater subjective fatigue terminate exercise earlier, does this mean that they might be getting less of an adaptive stimulus for each bout of exercise? And then if so, I think you kind of touched on it in your final slides. Do they need complementary therapies as well in order to get the same bang for their buck?
I'm not sure what you, it's a good point. I'm not sure what you call a complementary therapy, like electrical stimulation, that kind of thing.
That was what I was thinking of.
Yeah, but in the end, it's not because you do electrical stimulation that this is much easier. I mean, I don't know if you are experienced with electrical stimulation, but this is not much nicer than doing voluntary contractions. So this is still exercise. This is still some kind of discomfort, or so this is still exercise in the end. But you're right. They are getting less stimulus, and this is definitely an issue. So that's why they need to start slower and then to get used to that. And some people are even what we call kinesiophobic. I don't know if this is a word in English, but so if you're like that, obviously you don't want to do anything. So you have to start from the bottom and then slowly increase the amount of exercise and they can tolerate. And the fact that you need fatigue to improve your functional capacities is well known. So there are studies, for instance, with the COPD patients showing that the people who are not experiencing fatigue because they stop earlier, and this is the case also in one of the first studies that I showed in cancer patients. So it wasn't our study, showing that they stop with a much lower peripheral fatigue. So of course, if you have a much lower peripheral fatigue because you disengage earlier, you cannot expect getting the same stimulus as if you are going further. So yeah, it's a very good point.
I really like the idea of the tailored interventions from Rosie's paper.
We don't have the result yet.
That was my next question.
It's a tough and long study, as you can imagine, and all those clinical trials are pretty. I mean, I'm relatively new in that field, or I'm new in that field. I have done mostly neuromuscular fatigue experiments, and I can tell you that this is much, much easier. This is not easy, but this is easier. So hopefully we'll be successful. But it's I don't know yet.
Okay, sounds good. Callum Brownstein, you've just raised your hand.
Yes. Thanks for the talk. I wanted to ask about kind of displaying the relationship between fatigability and chronic fatigue. So obviously there's a conceptual relationship like you showed in your slide, where fatigue accumulates throughout the day because of fatigue resistance, and we've shown correlations between chronic fatigue and fatigability. But I wonder if you know of any studies that have sort of looked at the dynamics or the kinetics of fatigue throughout the day. So I'm just thinking that if you were to have patients report their fatigue at various hours throughout the day and measure their physical activity, you could provide more support that their physical activity is related to their fatigue. Do you know of any studies doing that, or is that something that you'd like to look at?
I don't know any studies, so since you don't have anything to do next week, I'm suggesting that you're doing that.
Okay.
No, seriously speaking, I think this is a very good idea. This is something we could talk about. I don't think there is anything. If anybody knows anything on that topic, of course, we'll be happy to hear that. I don't think there is anything like that, but yeah, that could be a good idea, and we should also examine this idea that we just discussed with Paul about the acute exercise, if we have the same thing, because in the figure that I showed saying that there is a ceiling, maybe the ceiling is actually not a ceiling. Maybe the threshold is actually lower for the fatigue people, and if they are feeling like fatigue and they say, okay, no, I have enough for the day. So maybe this is not even a ceiling. This is even worse than what I described on the slide. Oh, the people have suggested this. That was not my slide, basically. But,
yeah.
So yeah, I think it's a good idea. So we'll
yeah, I was just thinking of Dominic Micklewright's study where he validated the rating of fatigue scale, and they had participants wear accelerometers throughout the day and throughout the week, and then they measured fatigue using the ROF scale at different time points throughout the day. So that could be one way we could do it.
Yeah, we could do, for instance, fatigability tests in the morning, at noon, and in the evening, of course, different days, and check that and do the questionnaires at the same times, or at least the rough at the same time. Yeah, I like the idea.
Cool. Thanks, Gabe.
Thank you.
Ken has asked, how is fatigue accumulated and where? In chronic fatigue with cancer, MS, or other conditions?
Fatigue accumulated with what do you mean, Ken, by accumulated?
So you said that fatigue is accumulated over a day or over sessions. So, but how exactly fatigue is accumulated?
Sorry, I thought you were talking about byproduct accumulations and stuff like that. So the subjective fatigue, well, that was like a very basic diagram suggesting that this may be the case. No, we don't know. All we know is that people, and this is the reason why when we test people or patients during those fatigues, we always do that in the morning, because we suspect and we actually know that if they report fatigue, like if they were filling out the rough scale in the morning versus in the evening, it will be worse in the evening than in the morning. So that's why we test them in the morning. But the reason could be very different. So maybe this is related to the real fatigue accumulation they're experiencing during exercise, but it could be related to other things such as sleep disorders. If they have sleep disorders, then they will feeling the sleep deprivation maybe earlier during the day. I don't know, but that could be a reason as well. It could be mental fatigue, because of course both physical and mental fatigue they contribute to total fatigue, and some people are actually more reporting mental fatigue than physical fatigue. So in the questionnaires you can sometimes differentiate the two, not always. So yeah.
Okay, thank you.
Okay, if there are any further questions, feel free to raise your hand or pop them in the chat. But for now, I'd like to say thank you very much to Guy for his very interesting presentation and for allowing us time to ask questions at the end. And then thank you to everybody that's attended today, asked questions. If you would like to present data or ideas or a journal club or anything, you're interested in, get in touch with me, and we can pencil you in for the next few months. But yeah, I'd like to reiterate that. Thank you very much, Guy. Oh, Ricardo's asked one more question. It's disappeared in my chat box. Hang on. Go for it, Ricardo.
No worries, Paul. Thanks. It was, I guess, a quick one. I was just wondering, now that we're trying to tailor interventions to minimize burden in patients like cancer patients, if neuromuscular variables could be used as something we could look at to tailor the appropriate dose of exercise to deliver to patients to give the best benefit of exercise with less burden.
So, for instance, doing regularly MVCs during the training sessions, that kind of thing. Is that what you are thinking about?
Yeah, I was more thinking if the patient comes in and we could quickly assess the neuromuscular function on that day, if we could predict, okay, today would be the right intensity to give to these patients, so it wouldn't cause a great amount of accumulated fatigue, and it would be an appropriate dose for the patient to benefit from the exercise, or maybe that's too utopic.
Okay, it's another good point. So first, I would like to thank everyone for the questions, because they were all great. So thank you very much. So my answer to that one is that yes, I think it's a good idea. And the reason I'm saying that is that this is an idea I had, so that's why it's a good idea. No, I'm joking, but I actually applied to a grant for totally different topics, because that was for the Olympic Games in Paris. So we got some money from the French government. Well, we didn't get the money, we applied for the money from the French government, not much less than in UK in 2012, but that's a different story. Anyway, and one of the proposition I made was actually exactly what you described, but with athletes. And so my suggestion was to do, and I don't think if we do only an MVC or even twitch or voluntary activation, I don't think this is enough, because I would guess that most of the time they will be okay with that. But if you do a sustained exercise, of course you cannot do a 2 minutes, because this is probably too long. But maybe only a 30 seconds maximal voluntary contraction, even though it is not specific, but this is at least very simple, because if you work with athletes or even with patients, you need to have something very easy to use. So I was thinking, or at least proposing, that to do a 30 seconds MVC with voluntary, with electrical stimulation superimposed pre and post 30 seconds, and see if we can detect day-to-day differences. Whether or not this is possible with patients, I don't know, but I think with patients, and this is what we have been doing in Rosie's studies, for instance, the minimum you can do is to actually use the rate of fatigue at the beginning of each session, to make sure that they are not starting the session being at least subjectively fatigued. Right. So I think it's a good idea, and if
it would be good to examine,
to work on that, and I hope this kind of seminar that you guys have launched, hopefully could also be useful for that. So if we could have a multi-teams, multi-labs project, that would be fantastic.
Yeah, thank you.
Cool. We have Sylvia and Callum have raised their hands. I don't know if Callum's still raised from earlier. And there's a question from Ken in the chat as well.
Okay, maybe I can see that.
So yeah, the question from Ken says, you showed that peripheral fatigue is less in cancer patients, which occurs fast, peripheral or central fatigue in cancer patients?
Well, I guess it depends on the task. So here, that was not our study, if I remember well, there was no, I'm not sure they actually assess central fatigue per se. They just measure peripheral fatigue, and since the peripheral fatigue was lower at exhaustion, they said that is central. I think that's it. That's all they showed in that paper, and there is not much actually in cancer on that topic. And for our paper, as I said, the MVC differences at the last common stage in our bike test. So there was a difference between the two groups, but it wasn't explained by either peripheral or central fatigue. So
yeah. Sorry, I'm asking you many questions. Sorry about that. But actually, cancer patients, maybe peripheral fatigue is less because they cannot, I can say, exhaust the muscles so much because of the central fatigue. So central fatigue prevent them to have peripheral fatigue.
yeah, it's I don't think it's central fatigue per se. It's more central command. They disengage earlier, I would say, which is still central, but it's not what we call central fatigue as a reduction in voluntary activation, I believe.
Okay, Sylvia, you've raised your hand if you have a question.
We cannot hear you, Sylvia. You must have your mic off. No. Sorry.
No. If you want to.
Ah, here we go, I think.
Okay.
Yes.
Thank you for the talk. It was amazing. As a physiotherapist, I'm highly interested in the central command because that's mostly the complaint of my patients. It's exactly the central command. I want to do it, but I can't. It doesn't work out. That's what they say. Have you considered measuring the peripheral and central fatigue with the central command? Or do you know any studies that have been doing that to see the degree of the fatigue correlated with the degree of the central command deficit, if you could say that?
No, haven't considered that. So what will be your suggestion in so are you suggesting that we should measure, for instance, EMG during a fatiguing test? I'm not sure to fully understand what you mean by that.
For example, EMG and associating, for example, electrophysiological measures also.
Okay, I cannot hear you very well, but I think I understood. So when you said the patients told you that I would like to do it, but I can't. What do they mean by that? They can't because it's too because the discomfort is too high, or they just cannot contract. And which type of patient? I guess it's also important to tell us which type of patient you have.
Cancer patients, for example.
Cancer?
Yes.
During treatment?
Yes.
Or, okay.
Even post-treatment, they tell me that they can't. It's not because of fatigue. It's not because it is that causes discomfort. It's because the central command doesn't come out.
So I guess in your patient, just doing a measurements of voluntary activation, even at rest, if this is really the central command at rest, it should tell you if whether or not they are right or wrong. Because if this is the case, then you should measure a very low voluntary activation, and this is not central fatigue. This is called central deficit at rest. So yeah, maybe you could do that. You could do muscle stimulation, for instance, which is probably a bit more comfortable for the patients, or magnetic stimulation of the peripheral nerve. This is also something that we do with patients because for the same reason, it's more comfortable. So yeah, I haven't worked with a patient during treatment, and I don't think there are many studies. So maybe during treatment this is true. This is possible. I don't think this is possible off treatment. At least in our patients, we usually have relatively high level of voluntary activation, maximal voluntary activation at rest, even in highly fatigued patients. But again, that's only survivors.
Okay. Because it was exactly to tailor the program to what they feel. Otherwise, we are putting the expectations too high or too low, and we are not giving them the stimulus that they need. So.
But this is true, and this is what I suggested in my last slide. If this is happening, and I put that, but without even knowing if this is possible or not, but it may be possible, and what you are saying probably suggests that this is possible. Then yeah, probably the type of training that you may want to do is to not do many repetitions, but ask them to do their max. to
Exactly.
try to, at least we have to try. I don't know if this will be successful or not, but yeah, so it's another good point. Thank you.
Thank you.
Okay, thank you very much, everybody. Again, we'll probably meet early on in November. The speaker and the date will be to be confirmed. Thank you very much, and I'll see you all next month.
Thank you again, Paul. Bye-bye.
Bye. Thank you very much.